6 levels of consciousness explained. We start with coma. In 1974, neurosurgeons Graham Teasdale and Brian Jennett created the Glasgow Coma Scale at the University of Glasgow. A coma score of 3 represents total absence of verbal and motor responses. Brain oxygen consumption drops by over 50% during a profound medical coma. Neurons in the reticular activating system fail to transmit electrical arousal signals to the cerebral cortex. Patients in a coma exhibit 0 voluntary movements or sleep-wake cycles on electroencephalogram monitor tracks. Reflexes like pupillary light response may be impaired or completely absent. Traumatic brain injury causes 40% of comas worldwide alongside cardiac arrest and severe strokes. Most non-induced medical comas resolve transition or stabilize within 2 to 4 weeks. Medically induced comas use anesthetics like propofol to lower brain metabolic rates by 60%. Reducing brain energy consumption prevents dangerous swelling after severe cranial trauma. Next up, vegetative state. Neurologists Brian Jennett and Fred Plum coined the term persistent vegetative state in 1972. Patients open their eyes and experience sleep-wake cycles without conscious environmental awareness. Brainstem functions remain intact, maintaining automatic heart rates, body temperature, and independent breathing. The cerebral cortex shows minimal metabolic activity below 40% normal capacity. Reflex responses like startling to sudden loud noises or grimacing to painful stimuli remain present. Patients do not track moving objects visually or respond to spoken commands. Functional brain imaging reveals rare islands of hidden cognitive processing in 15% of vegetative patients. These individuals can mentally imagine playing tennis to answer binary questions during scans. A vegetative state lasting longer than 12 months post-trauma is classified as permanent. Rehabilitation focuses on physical joint movement therapy and preventing secondary respiratory infection. Now stupor. Stupor is characterized by deep unresponsiveness where a person awakens only under vigorous physical or painful stimuli. The individual lapses back into unresponsiveness the second stimuli stop. Glasgow Coma Scale scores for stupor range between 8 and 10 out of 15 total points. Neurologists evaluate stupor using sternal rubs or nail bed pressure triggers. Drug overdoses, severe hypothermia below 82 degrees Fahrenheit and advanced liver failure cause 60% of stupor cases. Metabolic toxins disrupt neurotransmitter firing across thalamic pathways. Speech during stupor consists of unintelligible moans or single disconnected words. Motor responses are strictly defensive, like pushing away a painful stimulus. Emergency treatment requires immediate airway stabilization and intravenous glucose or naloxone. Prompt medical intervention prevents irreversible neuronal loss within critical brain regions. Let's proceed to delirium. Delirium affects up to 30% of hospitalized older adults and 80% of intensive care unit patients. It causes sudden fluctuations in attention, spatial disorientation, and vivid hallucinations. Acetylcholine deficiency combined with excess dopamine release disrupts normal neurotransmitter communication. Brain scans show generalized slowing of background electrical brainwave frequencies. Patients experience severe sleep-wake inversion, mistaking night for day and becoming hyperactive at dusk. This nocturnal confusion phenomenon is medically termed sundowning. Severe urinary tract infections cause 25% of sudden delirium cases in elderly patients. Inflammatory cytokines cross the blood-brain barrier, disrupting delicate neural network processing. Hospital stays extend by an average of 5 to 10 days when delirium develops. Early mobilization, hydration, and reorientation protocols reduce delirium duration by 40%. And then somnolence. Somnolence represents an abnormal state of extreme drowsiness where a person drifts off without continuous verbal stimulation. Simple spoken voice or gentle tapping rouses them immediately. Reaction times slow down by over 300% during severe somnolence episodes. Cognitive processing drops, leading to slurred speech and incomplete sentence structure. Sleep apnea causes severe daytime somnolence, interrupting breathing up to 30 times per hour during sleep. Blood oxygen saturation drops below 85%, preventing deep restorative rest. Medications like antihistamine, sedatives, and opioids cause 45% of acute somnolence cases. These substances bind to histamine H1 receptors, depressing central nervous system alertness. Driving while experiencing severe somnolence multiplies vehicle crash risks by 5 times. The brain experiences micro-sleeps lasting 1 to 15 seconds without conscious warning. Transitioning to full alertness. Full alertness is defined as complete orientation to person, place, time and situational context. Glasgow Coma Scale scores reach a maximum 15 out of 15 points. Beta brainwaves operating at 13 to 30 Hz dominate electroencephalogram recordings during active focus. The prefrontal cortex actively executes complex logical decisions and long-term planning. Thalamocortical loops fire up to 40 times per second to synthesize sensory inputs into a unified conscious experience. Dopamine and norepinephrine maintain active working memory stores. Chronic stress elevates cortisol, reducing full alertness focus by 35% after 14 days of sleep debt. High cortisol damages hippocampal neurons essential for retaining fresh information. Maintaining full alertness requires 7 to 9 hours of sleep, hydration and balanced blood glucose. Regular physical exercise increases brain-derived neurotrophic factor by 20%. Consciousness exists along a continuous biological spectrum managed by the Reticular Activating System. Neurological assessments continue saving lives by accurately mapping these arousal states.